St. Monica Catholic community. And Melissa, can you share who you are? And you're on mute.
Oh, go on?
Oh, go on.
Okay,
Okay, Rick.
you're on mute
Oh,
too.
that was a good lead-in. Rick Stoff, Volunteer Collective, and my group generates more volunteerism out there, and I've worked with a number of you in the past to just get people to volunteer more.
Great, thank you. Lori.
Good morning, everyone. My name is Lori Peralt. I'm with Catholic Charities of Los Angeles. I am the regional director for the greater Los Angeles region, which is the Our Lady of the Angels region. And my office is in Venice at St. Robert's Center. So glad to be back. It's been a while.
Welcome, great.
Yeah.
Thank you.
Melissa.
Yeah, hi, I'm Melissa Couch with St. John's Presbyterian and also with the Assistance League of Santa Monica. It's another resource that does good, but also just to know that that's a resource that's so available. It's fascinating.
Good. Welcome. Thank you, Melissa. Nancy.
Hi, I'm Nancy Watson. I'm a member of Grace Lutheran Church in Culver City. And I'm also on the board of West Coast Care, which is a social service agency working on the beach in Santa Monica.
Great. Welcome. Teresa.
Good morning, I'm Teresa Heim, and I'm the Director of Development at Westside Coalition. I work with Darcy.
Great. Welcome. Daniel.
I'm Daniel Tam. I'm the deacon at All Saints Episcopal Church in Beverly Hills. Where is that church? What is that church? And also chair of Interfaith Solidarity Network, consortium of various faith communities, about 34 of them out in the San Fernando Valley mainly. Yeah.
Great. Thank you. Welcome. Ellen.
Hi, I'm Ellen Caldwell. I'm from Westwood Presbyterian Church. I'm here to listen in and learn.
Okay.
We have two Ellens.
We have two
Yeah.
Ellens. We'll go to Ellen number 2 now.
Hi, Ellen Endo. I'm with the Little Tokyo Business Association, which operates the Business Improvement District. And we, as I said earlier, we share a border with Skid Row and have historically since, I guess, the early 1900s. So welcome. I mean, to our community, if you ever want to come, you please do. We'd love to share. Thanks.
Awesome.
Okay, great. It says A Mill, so I'm not sure what A stands for.
It's Anne.
Okay.
Hi, Anne.
Hi, I'm a networker. I live in Culver City, and I know Brian and Yvette for many, many years. And I worked in Santa Monica for 50 years, so I collaborated with a lot of different organizations. And as a volunteer now, I'm all over the place trying to help many different people. So I'm here to learn. Thank you.
Wonderful. Thank you. Thanks for being here. Paul.
Yeah, hi, I'm Reverend Paul Elder with the St. Aidan's Episcopal Church in Malibu. I work down there and also with Hope of the Valley and about my father's business in the San Fernando Valley.
Okay, thank you. Welcome. Kathleen. Oh, you're on mute, Kathleen. Sorry.
Good morning. My name is Kitty Sankey. I'm a deacon at Westwood Presbyterian Church. And like Ellen Endo, I also serve on Little Tokyo Business Association.
Great. Welcome. Thank you for being here. Brian.
Hi, I'm Brian Navarro. I work for the Department of Mental Health. I'm the Health Neighborhood Liaison and the Faith-Based Liaison. My pronouns are he, him, his. I also attend church. I attend an inclusive church called Metropolitan community churches in Hollywood. Thank you for having us.
Great, thank you for coming. Tora? You're on mute.
Can you hear me now?
Yes.
Hi, good morning, everyone. I apologize for being late. The link wasn't working for me. But I'm Tora Miller from Department of Mental Health. My pronouns are also she, her. And so just thank you for having us.
Wonderful.
Yvette, I haven't seen you in ages. Yvette, are you around? She may have.
I'm around trying to unmute.
Okay, all right, there you are. Good to see you.
Good morning, everyone. So happy to be
Morning.
here. Haven't seen you all in a long time. And hi, I seen you waving, Ann. Good to see you. And Nancy. So a lot of you I have not seen. Dallas and Darcy. Pastor Mark, I see you here and there. So just good to see all of you all. Happy to be here. Happy to hear the presentation. And I guess let me backtrack a little bit. I am Yvette Rubin from Department of Mental Health, Service Area 5. I am the Outreach and Engagement Liaison, and I help coordinate our SALT, which is Service Area Leadership Team for Department of Mental Health in Service Area 5. Thank you for having me.
Did we lose Dallas? Where did Dallas go? Well, when she comes back, we'll get her going again. And Francis, is that you? At Culver City Presbyterian Church, Francis? Well, that would be Pastor Francis at Culver City Presbyterian Church. Well, while we're waiting, have we missed anybody that came on that's here? Okay, well, why don't we turn it over? Oh, here comes Dallas again. There you go, Dallas. Are you there? Okay, you're on mute.
I am here.
Yeah.
I don't know what happened. I got completely jumped off my computer. So anyway, back here, and I think, do we go on now with inviting Pastor Mark to share with us first?
Well, we just have Rebecca left. So if you want to introduce yourself, Rebecca.
Hi, everyone. Thanks for the welcome. I'm Rebecca Bijor. I'm at St. Joseph Center, and I'm a Unitarian Universalist pastor as well. So I'm doubly supposed to be here with you this morning. And I'm sorry, I was a little late. Good to see you. Wow.
And there's Francis.
Great, Francis.
Sorry, I was getting connected. Francis Rosenau, pastor at Culver City Presbyterian and board member.
Yes.
Wonderful. Great. Welcome.
All right. So go ahead, Dallas.
Okay, so again, we shared earlier that our focus today is when you encounter situations with someone who's mentally ill, and particularly situations where maybe we should not be entering, or be careful about how we enter or how we interact. And this situation came up, actually it came up in a meeting a couple months ago, as I shared earlier. And we've asked Pastor Mark to share with us a little bit about what happened. And then we have a great panel that we'll have Darcy introduce. They've kind of introduced themselves, but share a little bit more about them to share about some maybe strategies for us. So Pastor Mark.
Thank you, Dallas. And I'm sorry I can't see you all. I'm on my phone. I'm having internet problems as well. I was telling the first comers to today's gathering that you are all angels. The compassion that you show for those in need oftentimes puts us in harm's way unwittingly. We are so attuned to wanting to help and reach out as far as we can for supportive services and whatever the person may need, that we forget how vulnerable we are. I'm no different than anyone else. I am a pastor at Westwood Presbyterian Church. I'm the Director of Mission and Outreach and Pastoral Care. And I have the innate ability to not be afraid of anything and anyone, despite how animated they may be when I encounter them. I had the fortune or misfortune of having a brother who was schizophrenic for 40 years until he passed away, a veteran, Marine Corps. So I was accustomed to being around that element, and I'm not very excitable. But we are often vulnerable because we cannot anticipate the unpredictable volatility that might follow when perhaps we cannot give the person who has come, perhaps seeking resources or not. We don't know what their reaction is going to be to our either asking them to leave the property or that we cannot provide what they are asking for. And that was what happened in my case, except there was a bit of hate crime, racial epithets, and just vulgarity that was hurled at me. And I looked away for maybe a second and a half. And when I turned back, the guy was running at me with his arms extended, pushed me backwards. I fell backwards down a wheelchair ramp, a concrete wheelchair ramp leading from our parking lot. And as I was scrambling to my knees, he kicked me in the head. 20 days later, the headache had become so intense I could not bear it. So I drove myself back to the hospital and found out I had bilateral subdural hematomas. And I have been relegated to being at home, deployed, if you will, a la the pandemic, just more intently since August 30th of 2021. Never thought I'd be here like that. But those are the consequences of even the slightest lapse of presence when we are trying to attempt to help someone that is in need of emergency services. We ought to consider it being an emergent situation right from the beginning until we find out that it's not. Your safety is paramount. You can't do anybody any good if you are incapacitated in the process of trying to extend resources. I hope that's helpful.
Thank you so much, Mark. Thanks for your vulnerability and sharing with us. Before I turn it over to Brian, I want to share about a personal experience that I also had. And it was just recently, I had been talking on the phone with a homeless man that he's a veteran, lost his card, his wallet. And so he's been eating at St. Joseph Center at Bread and Roses Monday through Friday, but he called me on a Sunday and he hadn't had any food for 2 days. So I agreed a time in a, where he was parked to bring over some food. So I, went to a fast food place, just intended on handing it through the window and leaving because I was alone. We teach people over and over and over, never do this alone, never encounter somebody alone. And I intended to just hand it through the window and he wasn't there. And so I parked my car and I walked up to his car to put it inside. And while I was doing that, the tent that was right by my feet, a fight erupted. And the girl was screaming that he's choking me. And then she started gurgling. And so I started screaming. And then I started kicking the tent to try to get him off of her because I could hear that she could not breathe. And as I was screaming, 3 other adults came running. We're all screaming, we're calling 911, which all 4 of us did. 911 went to voicemail for every single one of us. We could not get an officer. So I continued to kick this man against my better judgment. You know, what do you do if somebody is dying next to you? I didn't know what to do. And finally, she got free and climbed out. We made sure she was okay. And then I realized I'm standing here in suede boots, in human fecal matter. And I was angry. I was angry at the situation. I was angry that we couldn't get help through 911. I was angry at myself for breaking my own rules, personal rules. And I just realized how dangerous it was. This man was really large and I am not. And so these are the situations that even when you know better, I just made a terrible error in judgment. So on that note, I'm going to turn it over to Brian Navarro with DMH.
Thank you for having us. Just to let people know, Tora and I have a presentation on some services, but Nick, the supervisor of the home team, the homeless outreach mobile engagement team, he'll patch in a little bit later. He's in a meeting, and I think help us kind of weave everything together. Yeah, I don't know where to start really, Darcy, like when just thinking about, I know I've had an opportunity to hear Mark's experience and talk about that, hearing your experience and, and I think first of all, I just want to say about how a confluence of many factors contribute to people becoming homeless, right? And that our population experiencing homelessness is very diverse, right? And why I say that is because, I had an opportunity to work for, my specialty is children's mental health. And I did my practicum at Children's Hospital LA, working with trans youth who were using survival sex to live, to survive on the streets. And then I worked at Department of Children and Family Services as a ER investigator, removing children from their home who've experienced neglect, sexual abuse, domestic violence, physical abuse, emotional abuse, right? And all these things that we learn in graduate school, homelessness, right? Being a child in foster care, all these traumas contribute to where people are currently at, right? Meaning that if that contributes to somebody becoming on substances, right? And that those substances begin to interfere with our daily functioning, that we can't hold jobs, right? And then you become homeless, right? Or that you're a trans youth and you get put out by your family at an early age, right? And then you're in the streets having survival sex, become HIV positive, right? Because of the risk you place yourself, and then you find yourself homeless, right? So I'm just trying to paint a picture of like some of the people that we experience helping who are homeless, right? Even in that situation, Darcy, right? I think about how, right, the incidence of domestic violence and violence, right? And that the women that we experience on the street are so vulnerable, right? I mean, subjected to those situations, right. I mean, so just to try to kind of paint a picture, and then there's people who experience severe mental illness, schizophrenia, and might not be doing substances, right? And have had this problem organically since 16, 17, right? And then really begin to lose connection from reality. We say reality testing. And these are the individuals on the street speaking to themselves, right? Or speaking to things that are not there. So really wanted to kind of paint this picture. And Nick's coming on right now, and his time's very valuable because he's actually doing some of the work. So Darcy, if I can, I wanted to kind of hand off to Nick Holt. Is he on? There we go, sir.
Yep.
So Nick could kind of explain in our continuum of care, because Tori will talk about psychiatric mobile response. Okay. I'm also going to talk about how NAMI and LAPD made a brochure of what you should do when calling, right? So we'll talk about that. But I wanted to give Nick the opportunity about our home team and how it exists in our continuum of care, how it's a specialty mental health, and how people are referred to this team. You up for that, Nick?
Thank you for that intro, Brian, and hello to everyone. I'm happy to talk a little bit about what I'm aware of related to when things it really comes down to civil rights of folks, right? So our continuum of care trying to encompasses the most intensive voluntary mental health services through our full service partnerships.
Nick, let me interrupt you just 1 second, not to be rude, but also because when you're patching in, just to give you a context, that Pastor Mark shared his story, which you're familiar with. Right. So remember the individual who had attacked him at the church, and then how maybe things fell through the system, but maybe we could kind of explain like police and how the legal system all kind of, and mental health and how complicated that is. But I just wanted to give you that context before you start.
Yeah, and thank you, Brian. I think the first step is to understand the state mandate of voluntary healthcare housing and income support, and the intensity, right, which is the FSP at the high end and outpatient at the lower end. Then you move to, I think, the realm that you're talking about, which is when somebody doesn't see a need to do something different when it comes to their healthcare, housing, or income support. And this gets much more complicated very quickly. So of the folks that have a mental health condition and who do not wish to explore different, within DMH, there's definitely the co-located law enforcement teams. In our sheriff's jurisdictions, those are the mental evaluation teams. In our City of LA jurisdiction, those are our SMART teams. So they are out there with law enforcement. Law enforcement can call those clinicians in to conduct a mental evaluation. Those individuals can do 5150s, send folks to the hospital. It poses another challenge though, when you have civil use of force and law enforcement backing off of forcing people onto gurneys for civil issues, not criminal. So that's another dynamic within our system. And then once somebody gets to the hospital, they're not immediately medicated. There's a legal process for that, a Reese hearing. So within that 72 hours, it's possible that unless the person is aggressed or having a difficult time in the setting, that they may not receive medication until that court hearing takes place, which is usually within the 14-day window. And then as far as continuing on this thread through hospitalization and towards conservatorship, you then have the 14-day hold. You then have the temporary conservatorship, which is a 30-day hold thereafter. And within the first, I believe it's the first 5 days of the temporary conservatorship, you have the attending psychiatrist having to write a conservatorship application to move forward with the court process. The standard in our courts at this time for LPS conservatorship is the same as murder. So you have to prove beyond a legal doubt that an individual is incapable to manage their own activities of daily living due to a mental health condition. And that has to be proven in court with public defenders, county counsel, all these dynamics. So as you can imagine, which is one of the reasons why I think our director and others were pushing for LPS reform, this is an incredibly high standard within our system.
Not to mention also, as Nick is explaining, right, because there's these legal standards, right? You can't force anybody to take medication. So like Nick was saying, there's a Reese hearing. During this time, the person is parked or sitting in the hospital for those 14 days. On top of that, we got something called an IMD exclusion, the Institute for the Mentally Diseased, meaning that any hospital, any institution, I believe, Nick, correct me if I'm wrong, is it 15, 16 beds are excluded from getting payment. This is going to be our UCLA hospitals. This is going to be Harbor UCLA, all our large hospitals that have more than 16 beds. So sometimes early on when people were, when they were talking about dumping, right? Department of Mental Health, we get you to the door, right? Oftentimes we say we get you to the door if we place you on the hold. The attending physician, which is DHS or some medical hospital, gets them through the door, right? Because there's some kind of handoff, right? But even in these large institutions that need to get paid, right, there's also pressure, I think, on staff and folks that we can't hold these people indefinitely, right, without getting paid for our bed. So part of Nick's talking about some of this LPS reform. LPS stands for Lanterman Practice Short Act. Prior to LPS, these Congress people in our state assembly, this is when people were institutionalized in large hospitals, right? That if I had a child and parents said no, they're from birth to death, people were dying in these large institutions because they had no legal recourse. But these individuals, Lanterman, Practice Short, this is where community mental health came from, right? That they're dismantling these large institutions and that people are best treated in the community. And not only that, that people have legal rights to challenge, right, being institutionalized, or that people have self-determination. So I also just wanted to say that. Sorry about that, Nick, for interjecting.
No, and you're bringing forward a lot of what has led us towards this current state, which is that the pendulum was here back in decades ago, and people really had an issue with people just languishing in restricted and locked settings. We had concerns about that, and so there's been reform, the closure of the state systems. Another dynamic that happens in hospitals is that if you go to court and you're not able to prove that the person meets the criteria for LPS conservatorship, those hospitals, because that's not acute based on funding, they don't get paid for those days. If it's just a chronic condition, you can't just keep somebody in a hospital for time on end. So many of the private hospitals on the west side have let their LPS ability lapse. You may have heard about that with St. John's in the 90s, and I know there was at least another one.
Cedars
Yeah,
no longer has an LPS, right?
Yeah, right. And these are business decisions based on some of these dynamics. So yeah, Brian is acknowledging the lack of inpatient beds, also the lack of locations that can complete LPS conservatorship. I'm also bringing forth the incredibly high standard of LPS conservatorship. And so you have a bit of a logjam. I heard a DHS psychiatrist say that in general in our communities, we have probably 20% of our population, maybe it was less than that, maybe 10% of the population that just meets grave disability at any given time, any given day, 10%. Now we do not have enough beds for 10% of the population to be hospitalized for grave disability at any given time. And furthermore, there's a lot of advocates who are trying to dismantle any form of forced treatment or yeah. So there's a lot of complex dynamics taking place in our communities.
Dr. Sharon, last week, I believe it was last week, 2 weeks ago, had a presentation with UCLA, a study that he commissioned when he first started. And it turns out when looking at the data, and this is only data from admissions from really our county hospitals, because people also go to private hospitals, but it looks like 17% of the population experiencing homelessness, he uses a term fall on a psychotic spectrum disorder, having some kind of psychosis or schizophrenia. So, nearly a quarter of the population, experiencing homelessness, we would say, is on that, experiencing psychosis or a spectrum of that. So one, it's like capacity. Two, it's also like the law, also, us trying to, a movement to not criminalize mental illness. This is why you have these care courts, but that's on a state level. So many different systems kind of going in place really to address this, to address people languishing on the street, really not connected to services. So really kind of wanted to talk a little bit that, and I know Nick's time is precious. Maybe Nick, you could talk a little bit about home. What you guys are doing now, and really how are folks referring some of the most vulnerable to your teams?
Yeah, for sure, Brian. And the care court too, I think that might be stalled, that whole proposal for some of these dynamics that are going through. So it seems like an interesting program, but because of some of the dynamics, there's some pause to it. So as far as our program, our services, so in addition to assisted outpatient treatment, when you're talking about the folks that are not really open to considering different due to a mental health condition, you have assisted outpatient treatment for maybe the more danger to self, danger to other type of folks. And then you have a team like ours, which is the homeless outreach, mobile engagement, which is really, we're really trying to target, we don't hit the mark in every case, but we're really trying to target the folks that are gravely disabled due to a mental health condition, and also some sort of like a mortality risk. Due to that, the Board of Supervisors really tasked the program with the folks that are hidden in plain sight. So referral sources, typically we like to see folks not succeed through other mechanisms. So folks that are not able to really connect with the outpatient clinics, not able to connect with full service partnership, not able to connect with our outreach network, whether it's WASA, People Concern, St. Joseph Center, the E6, the multidisciplinary teams, they're still, for whatever reason, stuck due to the mental health condition and some sort of mortality risk. So that's typically when we'll either be consulted. We're in the CES meetings. We try to be a resource there, talk about resources through DMH, because DMH is a real vast network of programs. And if we think it's appropriate, just take on the referral, try to go out, to make contact, to engage. We're clinicians, not magicians, so we go through the process that every other human goes through, which is to just have a conversation and see what somebody might be open to, and try to take a path of an open door. We're a small team. We have two social workers. We have 4 individuals who are community health workers, may have their own lived experiences. And we have part-time psychiatry, part-time nurse, but those are limited. Hopefully we're going to grow in those areas, but that's our current structuring of our program and our team. We are the program that we've completed 1 LPS conservatorship from the street. That process took about 1.5 years. So it's an incredibly, it's a high standard and a lot of due diligence that's required. We're open. I mean, there's a referral form on Allen County DMH's website. We get referrals from, I know we're speaking to kind of the faith committee here, City of Santa Monica, either directly, the partners over at the People Concern, oftentimes from our mental evaluation team, clinicians who are on that team over there as well. So there's a number of different sources. But one of the dynamics, just as far as that I've heard, is that oftentimes police and fire will not like just do straight outreach. So there are always calls for service. So if they're not aware of a concern that a community member might have, then I encourage folks to always consult with those entities and or Health and Human Services Department over at City of San Marco. Is that helpful, Brian? Anything more you wanted me to dig into?
Thank you about that, Nick. What Nick was talking about, he kind of briefly mentioned about outpatient conservatorship. So this was one of the out of the box thinkings, how I just laid that context about like IMD exclusions, hospitals don't want to hold people. It's such a process, right? That our director talked about, what, let's do it on the street. Right. And so what Nick was talking about, the most vulnerable. And when we talk about gravely disabled, these are people literally rotting on the street, sores on their legs. I mean, I dealt with people, maggots coming out of their sore, right? They're being eaten alive in the middle of the street. And these are the people that meet that criteria for grave disability, where maybe the hospital, because once they get the maggots out, they're good to go, right? But we know it keeps happening and recycling. So these are the people that now are being referred to Nick's team so that we do that paperwork. They even do the Reese hearing outside. This is why Nick's talking about having medical professionals now, because we can do baselines, right? Weigh people on the street, check their vitals. And part of doing a medical like grave disability is to demonstrate through evidence, right, that their physical medical condition is deteriorating, right? And this is part of getting some of that evidence so that we can conserve them. And just to define to this group what conservatorship is, it's a court case where a judge appoints a responsible person or organization called the conservator to care for another adult who cannot care for themselves or manage their own finances, right? So that once they're conserved, that if they were receiving some kind of disability or SSI or some funding, the conservator can use that money to place that person in a home or start to make some decisions of care for the individual. So just kind of wanted to explain that. I know Nick had to, leave, very busy. So I was so thankful for him to patch in. Oh no, you're there still, Nick. So
I'm still here.
Can
did I hit it on
we
the head about the conservator?
Can we have the one question for Nick? I know you answered it in the chat. Can you expound on that? Rebecca had asked, what does success look like for your team or for an individual in your care, just so everybody else can benefit from your answer?
Sure. There's a part of me that wanted to say not working with our team, but I guess that's, I mean, we're a safety net, right? So like we want to help soften people's landings so they don't crash all the way through to death or some other adverse outcome. But ideally, the other way is we're trying to bring people back into care. So I mean, there's so many options for people to enter care, enter wellness, enter housing, and we need all of those answers and solutions. There's no one right, wrong, good or bad. So ideally, connecting the services, connecting to housing, sustaining those relationships, sustaining those placements. Best case scenario is always helping folks find their own ways with support into sustainable care and housing.
Is your team just West Side or are you countywide?
So we're a countywide program. Our team is Service Area 5, which is Malibu to LAX to Culver City to Beverly Hills, give or take. But there's a team in every single service area. In some places, there's more than one. For example, in Skid Row, there's a Skid Row dedicated team, and there's also a Service Area 4 team.
And Lori wanted to know, what steps do we take in real time when we encounter a struggling unhoused person at a program we're operating?
Hate to do the therapist answer a question with a question here, but I guess it depends on the situation. If somebody, I mean, ideally, any sort of empowering an individual into stability, into wellness, into de-escalation is going to be great. So if you have somebody who has a good relationship with that person, what can we consider doing different? I'm worried about your safety. What can we do to kind of keep you safe right now in this moment? And then also, moving from support to limits or to directiveness. I am concerned about you, and it seems like you're not in a place that you're able to kind of consider a different option. So I'm thinking it might be a good idea for us to call PMRT together, to have a conversation with somebody just to see if maybe it's a good idea to go to a hospital. Can we get you over to Exodus Urgent Care? Can we get you to the local hospital just to kind of take a break, just relax? And those are a couple thoughts off the top of my head.
If it's a person that they're not working with, but just shows up and they don't know who this person is, what would you suggest?
Yeah, it's our team. I was a frontline staff, and our team definitely has these kind of cold calls, if you will, where you're just engaged with somebody. You don't know where they're coming from. You don't know if they're ever going to return. You want to try to leave that person with some information. I always think it's a good policy to try to get to know someone a little bit, where you're coming from, how's it been out here, if they're able or capable of having that sort of a conversation. Do you know where to go? Do you know where to go to get mental health care? Do you know where to go to get medical care? Do you know where you could get a meal? Having those conversations, and then if they're struggling to have those conversations and you see that the impairment is deeper, then I think there's a real process you have to go through. So PMRT, and I know Tora is going to talk a little bit about this. It is not emergency response. So they will not come out immediately to check in on what your situation is. They can dispatch a team, the team could be available, it could not be available. I know we're potentially moving to a 24/7 model. We're not there yet. So you're talking about times between 2 hours and 5 hours. You're talking about ambulance times. Even if the team makes the decision to send the person, you're talking about ambulance responses, which have been kind of ridiculous of late, anywhere, again, between 45 minutes and like 5 hours, I've heard, which is wild. Then you have the added variable is the person going to get on the gurney? If I know the person's going to get on the gurney, okay, easy fix. But if they're not, which a lot of folks, when they're stuck, they don't really want to do anything, explore anything different. Then you have the involvement of law enforcement. So you're talking about a potential 6-hour process here. So knowing that, the only options that are left are law enforcement and fire and 911. And if you have an emergency, even if it's a mental health emergency, you just got to use the resources that are available. Remember too, and this connects to a couple of the chat comments that I'm trying to track, certain law enforcement units have co-located DMH staff in them. If there's a chance that there's not enough units or resources available, so it's possible that they may not be able to deploy the resource that's needed exactly in that time, but you got to use the system that exists. So it's possible that Veronica or Kim could respond to a City of Santa Monica call. It's possible that our SMART teams could respond to LAPD call. LAPD has their own mental evaluation unit. That's a dedicated unit that responds. But typically what happens, because the resources get backed up, is that there'll be patrol will respond, they'll make a judgment, they'll make a call. If they need to kind of detain the person to await a conversation with a mental health specialist, they'll do that either in the car at the location, or they might take the person back to the station and have that conversation there for an evaluation. It's an imperfect system. It's not enough resources to meet the demand that I think we're seeing, but that is the existing process as I understand it to be. Is that helpful?
Excellent, excellent. I don't know if you need to leave Nick, you do what you need to. Your
I'm
team
okay, I
is
got
on
time.
top of it.
Darcy, give me the ability to share. I wanted to share the NAMI and LAPD brochure, right? Because I think that's what Pastor Mark is talking about. And this was developed in conjunction with NAMI West LA and LAPD. And just like Nick was saying, right? I mean, when we really think about, some of the questions, what are you trying to do, right? Are you trying to get the person connected to a resource about housing? That's LA Hop, right? LA Hop is the website, right? And really about building that rapport, because you're trying to get as much information for whatever outreach team is assigned can connect to that individual, right? LA Hop. If, like Nick was saying, if it's an emergency, always call 911. Always call 911 for immediate response.
What happens when they don't answer?
I got an answer for you for that. Because even for PMRT, sometimes that happens, right? Unfortunately, that's not part of a system we manage, but sometimes calls don't get picked up at 911 because they're inundated. I was part of PMRT, and in the areas that I'm assigned, I always get the phone for the local station so that I could call direct, right? That I have the LAPD West LA station, I have the LAPD Wilshire station, because there's always an attendant there that's going to pick up the phone. I have an emergency in your area at blah, 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 blah. And that's what we should have in our phone if you're in certain areas, right? If you're in certain areas. Pastor Elder, I know he works in Malibu, but the corresponding sheriff who responds is in the Valley, right? Get that phone number for that Valley station. So that would be my answer about that. If a person, had medication, was looking to get a medication prescription or needed mental health stabilization, I would say our urgent cares, right? And our urgent care in West LA is Exodus, next to the DMV in Culver City on Washington. Open 24/7, or I think they say 23 hours out of the day, but a person can get stabilized there. They can get a 30-day refill of their psychotropic medication. So once again, what are we trying to do for the individual? Get them housing, LA Hop. Get a medication referral, urgent care, right? The person is experiencing behaviors that endanger themselves, me or the community, 911, right? So just to kind of lay down our system of care. You could call Access, right? If you're looking for a person's pretty stable, Darcy called me. She was saying she was a little depressed or anxious after seeing some of the things that have been going on in the community, these shootings. I would maybe say, Darcy, call Access because they can give you referrals to the closest clinic near you, right? Already in my mind, I'm starting to triage how severe is this situation, right? And what is your capacity? Sometimes we think about, as professionals, your scope of work, right? Like, what is your scope of work? And sometimes we remind people, stay in your lane, not because, you're not trying to help, but about safety, right? And always in pairs, like Darcy said, when, Nick and his team, PMRT, always in pairs, because when things go sideways, they go sideways in less than a minute. And that's why you have that individual there, one, to call 911, or two, to help protect you a little bit. Yeah. I know I wanted to give Tora an opportunity because she's really does psychiatric mobile response and can tell you a little bit about the people that are the best fit for that type of service and kind of what they do.
Hi, everyone. Good morning again. I've been listening to what Brian and Nick have been saying, and one thing that I wanted to point out has to do with mental health rights. Excuse me, I'm getting over COVID, so I still have a little bit of a cough. I don't know if I'm able to share, Darcy.
I just made you a co-host, yes.
Okay, so I wanted to quickly show you all. Trying to see if I can get to it. So I told her that this is what Brian was talking about. This is the 911 checklist. So just real quick, as you all can see. And we actually can send this to Darcy and Darcy can share with the group. And this is very good for when you're calling 911. Brian talked about scope of practice, and we have to remember that the police are there to investigate a crime. They come out to see if someone has committed a crime and to investigate it. And so being mentally ill is not a crime. And so when they're coming out, it's very important that when we call them, we need to let them know what we're calling them to come out and do. And so that way they can come out appropriately, if that means them coming out with a mental health team member, or they coming out and responding in a way where they know that they are not there to investigate a crime, but there to assess if this person needs to go to the hospital. LAPD is able to write a hold. I also believe the Sheriff's Department, they are able to write an involuntary hold, but again, they need that information. So these are just some things that you can give the dispatcher. So I just wanted to share that with you. But I was reading, I can't pull it up, but I was reading about our mental health rights, and people that are mentally ill, they have specific rights. And it comes out of a really large advocacy group that is called Mental Health of America. I don't know if you all have ever heard of them, but it's a really big advocacy group that's been around since 1909. And Brian talked about how they, he talked about people being in institutions a long time ago. And there's stories of where a husband could call the police and say, oh, my wife is acting crazy, and they would come and put her in an institution. And so from that, you know, a lot of laws was made, a lot of advocacy. And I just want to read to you quickly the rights of a person. And this is really the rights of anyone, but specifically the rights of a person with mental health and substance use conditions, which are the right to liberty and autonomy, protection from seclusion and restraint, community inclusion, access to services, and privacy. And so, and you can read more about this on Mental Health America on their website. But the reason why I'm pointing this out is that these are morals and ethics that us as professionals that we have to abide by. Even our department, this is something that we abide by. And so the point is that we just cannot go out and just pick up people off the street because they have a mental health condition. We have to respect their civil liberties, and there has to be a criteria that they meet in order for us to put them on an involuntary hold. And so when we look at our psychiatric mobile response team, that is basically a team that is an alternative to law enforcement coming out. The team is 24 hours, 7 days a week, Monday through Friday, like I said, Sunday through Monday, whatever. And from 8 o'clock to 5 p.m., the response time is a little shorter because they operate with teams that are in each service area. So our county is divided. The county has divided our county into 8 service areas. I'm sure you guys know that. So in every service area, we have a PMRT team. So the 8 to 5, they're able to come out. They have more teams that are available. But after 5 o'clock, it's overtime and the teams are more sporadic. We don't have as many teams. And so that's the reason why Nick said they're not first responders. It's not going to be when you call 911 that they're going to come out very quickly. There is a priority with PMRT. Children are going to be number one. Children who are wards of the court, who are in foster care, who are under DCFS are going to be number one. And then it's going to be adults from that point. And also people who are in hospitals. So that's the reason why the time of them coming out could take a little longer, because they are going to go see children first. But with the psychiatric mobile response team, anyone can call. You do not have to be a mental health professional. Anyone can call. And the purpose is for them to come out and to assess to see if the person needs to be placed on a 5150 hold, that's for adults, or on a 5585 hold, which is the code for children. And the criteria for being put on the hold is if they're a danger to themselves, which means they have suicidal ideation, they're having thoughts of suicide or an intent to act on suicide. If they're a danger to others, homicidal ideation or an intent to act, or gravely disabled, which means that they are unable to provide or access resources for their self-care due to mental illness. We always come out in pairs, and it's our determination if we feel like this person cannot keep themselves safe. There are instances where the person may be experiencing mental health symptoms, but we do not feel like it's at the level of where they need to be hospitalized. Based on talking to the family or whoever their support system is, also talking to the client, and based on what they tell us and based on the history, sometimes we make the determination that we can leave them with some resources and we can connect them to mental health treatment. So that does happen. There are also cases where we feel that we do need assistance with law enforcement. And that could be that the person is so symptomatic and we have determined that they do need to go to the hospital to be assessed. Excuse me. And so we will contact law enforcement to come out and assist us. And what that does is that their presence, majority of the times, will, one, help the person to de-escalate, and will also help the person to be more consenting to going to the hospital just by their presence. Most people do not want to get arrested. They don't want to go to jail. And so that is how they can help with that. LAPD or Sheriff's Department, they will not detain the person. Again, they usually will only detain if the person at that time does something that puts us or puts the people that are there in danger. They, again, come out to just assist. So that is how PMRT works. I see some questions. Oh yeah, so we put the number for PMRT. Is there any other questions regarding PMRT or anything that you want to understand?
That was just so concise. I look forward to the written material. That was
Yeah,
so
I'm gonna say, it was very concise. Thank you.
You're
So,
welcome.
so important, and it's complex. You know, when Lori had asked in the chat about doing training for staff, and that DMH does offer a training for staff members, because, you know, if you've got people wandering in off of the street, you know, is your staff at risk? If so, then utilize that training for sure. You know, this is all such good information, and, you know, it's unpredictable what might happen. It was unpredictable for Mark. You know, never in a million years did he think that that would happen. And, you know, it's such good information, and you guys have such an incredible team and such a big job. My goodness.
I wanted to share also, Darcy, I don't want you to feel any guilt. I could hear it in your voice, just the guilt that you felt about helping this person. I put in the chat that we have to start with where people are. That's like the first lesson that we learn when we start in school. And what that means is that, it was a question also in the chat about, well, when someone comes, just say someone comes to the church or to my program, and what do? We start where they are. The first question you should ask them is, what do you need help with? What would you like? because it may not be housing, it may not be mental health resources, it may not be going to the hospital. It could be simple as that. I just want something to eat, or I want a drink of water, or I may want to ride here. And so let's not assume that this person wants all these things. I think as helpers, we see a person, and because they may not look to the standard, or we feel like everyone should be in a home, everyone should be clean, everyone should look a certain way, no one should be going in without food, that we want to rush in and start providing all of these things, and that may not be what the person wants. And so just start simply with that. What do you want? And if you're able to provide it, that's great. If not, then you can provide them resources on where to get that, and tell them, I don't know where to get that at. I can give you a number, or I can call. And again, always work with teams. The other thing, we have to also contain our anxiousness. And Darcy, I'm going to use you if you don't mind, because you said the person called you and he said he hadn't ate in 2 days. And so for us, it's like, oh my gosh, he hasn't ate. No one wants to be hungry. I need to go out. But one, it was a Sunday. You know, that's usually a day of rest. Two, do we know that it's been 2 days? You know, not to say that he's lying. Is he going to die? Is that an emergency? No, we don't want him to be hungry. But when I kind of assess it, is it safe? I don't have anyone who can go out with me right now. You know what? I understand that you're hungry. Here's a place that you can go to. I can come out tomorrow with my friend and bring you something to eat, or I can come out in a couple of hours. We have to, safety is number one. I thank God that nothing happened to you, Darcy. I thank God that that woman was there. God might have put you there in that place to protect her. But like Brian said, it only takes a second for things to turn and go the wrong way. So, you know, it's good for us just to stop and think, because everything is not an emergency, and someone else's emergency is not necessarily our emergency. And that's something, and we're telling you things that we have to tell ourselves, because even us as professionals, we also do the same things, especially when we're connected to all of our clients, and we don't want them without anything. But we do always have to step back and kind of gather ourselves and say, okay, number one, and this is what we also learn in school, number one is safety. We will not get our license if we don't remember that. That's number one. We always have to assess for safety first, and then we go down a long list. So I just want to share that with everyone. And like I said, Darcy, don't feel bad. There's a gentleman who's at the end of my corner. I frequently go and give him food. I pull up just like you do. And, you know, he's always calm. But even you telling me that story, it reminds me that I have to always be safe, no matter how comfortable I feel with him. So I just wanted to share that. I'll turn it back over to Brian. Yeah.
Thank you, Tora. Thank you, Tora. Yes, you know, as we were really painting this picture of multiple systems, right? Multiple agencies, state, county, federal systems of payment and reimbursement. I mean, it's so tangled, you know, it's so tangled. But you know, that was, I think, if anybody else has any kind of questions or that we might be able to answer, I think kind of listed those steps in the chat, right? You know, I think if we're going to be calling 911, we're definitely going to pass that flyer to Darcy to, you know, pass out to people about when calling, so that we're just kind of prepared with the information that those individuals want. Yeah.
Awesome.
I'm thinking what might happen today is after this, we're going to have more questions. And so it's good to know, Brian, that we can always come to you and get info and and you can lead us as to where to get our questions best answered. I think Daniel Tam left, and I was very interested in Mr. Holt, you talking about some of the advocacy pieces that may be something we as faith leaders might want to look at. So I might talk to you particularly about that, but I was thinking we should talk to Daniel Tam about that because I know he's going to be leading up the advocacy group for I think it's for the whole coalition, right, Darcy?
Yeah.
And so this might be something we look at as faith leaders, is how are some of these situations defined? What can we do as faith leaders to help move it in a better direction? I don't know if that's the right word, but that seemed to be something that I know we've talked about before, and maybe something we could bring to advocacy.
Awesome.
So do we bring it to a close, Darcy, for now? I know it's past 10.
Yeah, this is such good information.
Absolutely.
I'll
Thank
copy
you.
the chat. I'll send it out also following this so that you guys have those links. And Nick and Brian and Tora and Yvette, thank you guys. Your team is incredible. And we just really, really appreciate the complexity of what you do, the compassion that you do it with, and just how difficult your days are, every day you're working. So thank you. Thank you for sharing with us. And if there are any additional questions, we will direct them, to you. Okay?
Thank
Thank
you.
you for having us. Thank you
Thank
so
you.
much. It was a pleasure.
So just to take a moment to thank everyone for being with us this past year. So this is our last meeting until September, right, Darcy? And now what might happen in the summer is we may have a planning session. So we'll let people know about that if you want to come in and connect with Darcy and I about looking at the coming year. But in particular, to let people know that we do have right now tentatively scheduled the I'm forgetting what it's called, the resource fair. We're going to try to bring it back. So this will be the first time, in 3 falls, that we'd be doing it. And it would be September 7th. And it'd be here at St. Monica. And we're looking to be outside so that, hopefully we keep away from any kind of germ that comes by. So that's the goal. So we'll send you more information. Again, thank you so much, Department of Mental Health, for being with us, and more importantly, for being with the people out there who need.
Before we get off, I'm sorry, Dallas. Before we get off, can Yvette make an announcement? We have an event coming up.
Yes, Yvette, please.
Yes.
Thank you, you all. I forgot about the announcement. Thank you, Tora. But June 17th, we will be out at Culver City Memorial Park under the shelter that's located on the Culver side from noon to 2. We will have a lot of the different agencies there that provide services. There will be opportunities to win gift cards. We have definitely a nice little swag bag with nice items in it for the first 100 people. We will have lunch. So lunch boxes from Panera. So please come out and join us. It's about well-being, well-being for our mental health. And 2, we want people to take care of themselves as a whole.
Do you have a flyer for that?
I do have a flyer. So Darcy, I will send it to you.
Thank you.
It may have came on a salt flyer, but I will give it to you. And again, that's our service area leadership team and the Westside Mental Health Network collaborating together. And this event is occurring, and it's called the Summer Celebration. Some people say, what are we celebrating? We're celebrating a healthy well-being coming out of this pandemic. Just celebrate ourselves. We made it this far.
Yes.
That's right. That's right. Thank you. It's a great note to end on. Thank you, Yvette.
Welcome.
Thank you, guys.
Thank you, everyone. And a big thank you to Darcy, who supports us all year and keeps us together. Thank you, Darcy. And a shout out also to our Reverend Francis Rosenau, who works with Darcy and I on planning many of the events. Thank you all for the year. We'll stay in touch. We'll see you in the fall for sure. Bye-bye.
Okay, guys. Bye-bye.
Thank you again. Bye-bye.
There's so much information that I'm looking forward to, Darcy.
Yeah, I know.
Thank you. Thank you
We
so
need
much.
Darcy putting it together.
Yeah.
So Darcy, you send us the chat, right?
Yep.
We get the ability to see what's on the chat and all
Yep.
that. That's so much info.
Yeah, there's a lot of good links in that, so it's very good.
The
Okay.
form that she had that you fill out for the police, for the 911 call, you know what I'm talking about? It was
Yes.
very
Yeah.
in-depth.
Okay.
You have that also?